Good day. I'm Domina Petric, medical doctor, resident physician for clinical pharmacology and toxicology in University Hospital Center Split, Croatia. My abstract is about pathophysiological similarities of Kounis syndrome and non-allergic acute coronary syndrome. Kounis syndrome can be defined as the occurrence of an acute coronary syndrome associated with mast cell and platelet activation in the setting of allergic or anaphylactic reactions. There are three types of Kounis syndrome. Type 1, coronary vasospasm or allergic angina. Type 2, native plaque destabilization or allergic myocardial infarction. And type 3, stent thrombosis. Based on the review article cited below, we know that Kounis syndrome can happen at any age, but the most common affected age group is 40 to 70 years old. Risk factors appear to be history of previous allergy, arterial hypertension, smoking, diabetes mellitus, and hyperlipidemia. The most common triggers appear to be antibiotics, 27.4%, followed by isthmus bites, 23.4%. Complications of Kounis syndrome are rare and include cardiogenic shock, 2.3%, cardiac arrest, 6.3%, and death, 2.9%. In a retrospective study conducted by Helbling and co-workers, which is cited below, researchers found that 226 individuals suffered 246 episodes of severe life-threatening anaphylaxis with cardiovascular symptoms with an incidence of 7.9 to 9.6 per 100,000 inhabitants per year. Death due to anaphylaxis had occurred in 3 subjects, making the case fatality rate to be 0.0001%. Well, we have to ask ourselves, is Kounis syndrome really a rare disease, or is it just infrequently reported in the literature and unrecognized in clinical practice? Nicholas Kounis hypothesized in his article, which is cited below, that Kounis syndrome represents a magnificent natural paradigm and nature's own experiments in a final trigger pathway implicated in cases of coronary artery spasm and plaque rupture. The same mediators released from the same inflammatory cells are also present and in acute coronary events of non-allergic etiology, which are not only present in the culprit region before plaque erosion or rupture, but they release their contents just before an actual coronary event. Based on the up-to-date published studies, we now know that there is a common or very similar pathophysiological pathway in both Kounis syndrome and non-allergic acute coronary syndrome. Increased histamine levels, increased serum tryptase and kinase levels, increased levels of arachidonic acid products, including thromboxane and leukotrienes, and increased interleukin-6 levels were found in both patients with Kounis syndrome and non-allergic acute coronary syndrome. When it comes to treatment of Kounis syndrome, we now know that treatment of allergic event alone, which consists of intravenous corticosteroids, H1 and H2 antihistamines, can abolish symptoms in type 1 Kounis syndrome or allergic angina. In patients with type 2 Kounis syndrome or allergic myocardial infarction, treatment consists of an acute coronary event protocol and anti-allergy protocol, meaning corticosteroids and antihistamines. And treatment of type 3 Kounis syndrome includes acute myocardial infarction protocol, urgent aspiration of intrastent thrombus, and anti-allergy protocol. What about non-allergic acute coronary syndrome and the potential use of corticosteroids in non-allergic acute coronary syndrome? Well, evidence on this issue is scarce, but I found this interesting study, which is cited below, conducted by Congemi and co-authors. This study was designed to investigate the potential interplay between corticosteroid treatment and in-hospital myocardial infarction in adults with community-acquired pneumonia. Results showed that in-hospital corticosteroid treatment was associated with a lower incidence of myocardial infarction in adults hospitalized with CAP. A meta-analysis of corticosteroid treatment in acute myocardial infarction demonstrated no harm and a possible mortality benefit of corticosteroid therapy in acute myocardial infarction. Well, taking into account that there is a common pathophysiological pathway in allergic and non-allergic acute coronary syndrome, which include mast cells and pro-inflammatory molecules such as histamine, tryptase, kinase, thromboxanes, leukotrienes, and interleukin-6 playing a crucial role, anti-allergy protocol, especially intravenous corticosteroids, could be beneficial in the treatment of non-allergic acute coronary syndrome as well. Early implementation of such protocol could prevent or mitigate myocardial damage, but of course, more preclinical and clinical research is mandatory. Therefore, this short abstract, I hope it will serve also as a research proposal. Thank you.